how we can address it, and stuff like that. Okay. Let's wait for a couple of more minutes, and then I think we'll get going. Okay, I think before we start, do you guys address C1 in particular? Let's have a little chat about this. You can answer on the chat box. And if you do, what kind of problems do you see? This is a topic of interest because I've seen wide variety of problems. A lot of times it's missed by providers, and headaches and dizziness are common symptoms. So we do associate with C1. We're going to talk about how and why. What else, guys? Cervicogenic headache is common. So that's a good one. Okay. We'll talk about reasons for it, clinical anatomy about cervicogenic headaches. Vertigo is common. What else? Feeling of vomiting, nausea is common. Yeah. What else? Balance issues are very common. That's a good one. Poor coordination is common. Balance issues are common. What else, guys? Incoordination. That's a good one. Yeah. Vision, I think I think you can see visual issues with it. We'll talk about it. We talk about diplopia and we talk about convergence, and I think we're going to talk about it. Okay. Headaches are common. Diplopia, you've seen diplopia is common. What else? Hypotension and sweating. I think problems related to sympathetic nervous system are common. Okay. And these are the common ones, but there are uncommon ones too, which we're going to talk about. Yeah, with BBI. Okay. What else? Hearing could be an issue. Okay. And I mean, if you look at it, I mean, hearing and incoordination could be related just because it's the same pathway. Okay. It's your vestibular cochlear nerve, right? And it's some of your extrapyramidal tracts that carries those stuff. Okay. Okay. What else, guys? Tinnitus. Okay. That can happen. That's a good one, actually. That can happen. What else? And it's related to the same cranial nerve. Okay. What else? Okay. I think you guys have covered wide variety of things. I've tried to compile this from osteopathic standpoint. I am close friends with one of the chiropractors who only treats C1. So I get some referrals from her and I've had several conversations with her. And some of the literature comes from chiropractic stuff. Backache, of course. I mean, it's all related. So it can happen without a doubt. Okay. Okay. I think I'll try to simplify things because if I just run through slides, you would not get it because it's a very complex topic. So there is a lot of material on the slides, but I can share the presentation on the group. You can go through the presentation. That's not a big deal. But the idea is to understand patient-related problems. Okay. So we're going to talk about patient-related problems associated with C1. Okay. And try to simplify it from like patient standpoint. Okay. Okay. I think let's get going. I think people will continue to join in, but let's get going. Okay. We're just going to talk about C1. I'm going to talk about basic anatomy. I think a lot of you might be familiar with it, but I think it's a quick screen. or quick review on C1. Okay, so if you see C1, looks something like this. Okay. Yeah. This is your first cervical vertebra. When I was in PT school, I don't think we spoke about this at all. And or even in like fellowship programs and orthopedic certifications, we spoke about this, but not in like the detail we should know about, which means that the wide variety of problems this misalignment can create is in abundance. I mean, stuff we see in the clinic is mind-blowing, because this can cause wide array of problems, more problems than you can think of. Okay, so we'll talk about this. Okay, so this is C1. It does not have a vertebral body. It does not have a spinous process. Okay, what it has is a very, very wide lateral moss, or the transverse process, and this is the only palpable structure. Okay, and I'll show you how to palpate it, how to make a sense of it. Okay, this is the only palpable structure. People who are very skillful, they can palpate the posterior arch. Okay, can palpate the posterior arch, but the only palpable structure is your transverse process. Okay, and it's very, very helpful if you know how to palpate it. If you understand the arthrokinematics and mechanics and positional faults, if you know how to palpate transverse process, I think it really helps. Okay, so the primary motion that happens is at C1 is the nodding motion, right? This motion. Okay. Okay. And when you do a no, okay, that's the rotation motion that happens at C1 too. So this primarily happens at C0, C1. This happens at C1, C2. Okay. Okay. It's probably the most common site of misalignment. Okay. Not all misalignments cause symptoms like SI joint. People can have SI joint issues, but no problems. But some of the misalignments, some of the instabilities can cause wide variety of symptoms. Symptoms that are severe, symptoms that are very complex, symptoms that most of the providers don't associate with misalignment of C1. Okay, and that's what we're going to talk about. Headaches and vertigo and incoordination, they are relatively common ones, but there are symptoms that are fairly uncommon, and your understanding of how to treat C1 can help those patients. Okay. Okay. So I spoke about nodding. I spoke about rotation. Okay. It protects the brainstem. We know that brainstem ends at upper cervical, foramen magnum, C1, and you have the spinal cord there. Okay. You see the foramen transverse area or transverse foramen. You have the vertebral artery here, and then your first cervical nerve is here. Okay. There's a groove for it. Okay. Okay. A little more on anatomy. You can look at it. It's a good view. Transverse process, which is what we are interested in, palpation. From palpation standpoint, you can look at the anterior arch. Posterior arch, we can palpate. I'll show you how to palpate the posterior arch. It's a little more curved. To hold the C1 in an anatomical position, make sure that the facets that are concave are superior. So superior facets of C1 are concave. The inferior facets that articulate with C2 are flat. Okay, and that's how, so this is the anatomical position. Okay, your odontoid process is here, which I will demonstrate. So this is how it sits. Okay, the superior facets are concave, inferior facets are flat. Okay, posterior tubercle, because it does not have a spinous process, you have a ligamentous attachment, ligament nuchae here. Okay, and there is a groove for the suboccipital nerve C1, dorsal ramus. Okay, if I have to show you the groove, I think this is, if I can show you, there is a small groove here. Okay, that groove is for C1 nerve, dorsal ramus. Okay. We spoke about lateral mass, we spoke about transverse process, we spoke about foraminate transverse area or transversarium. Okay. And then you have a bunch of ligaments. I think we're going to talk about the more important ones. ALL and PLL are there. Actually, PLL starts at C2. You have something called as posterior atlanto-occipital membrane, which looks like ligament flavum at C01. Okay, and then you have transverse ligaments. The more important ones are your transverse and alar. We'll do some testing for them. I think in our program we talk about them all the time. As an expert therapist, you should be able to assess these two ligaments. Apical ligament is very similar to alar because it connects the dens to foramen magnum, but it has less functional value. It has less strength. Okay. But just to understand it, I think apical ligaments looks like alar ligament. But alar is what we are concerned about. Transverse is what we are concerned about. Because compromise to these two ligaments can create instability and creates more positional faults. Okay. And can cause wide variety of problems, of course. Okay. Look at the key muscular attachments. Okay. This is the posterior view. And we love needling these muscles. In our dry needling course, we talk about needling these muscles. Make sure that you know the origin and insertion of these muscles. You have rectus capitis posterior major, originates from C1, attaching to the inferior nuchal lines. And then you have rectus capitis posterior major, originating from C2, going to the inferior nuchal line of foramen magnum. And then you have oblique capitis superior, originating from transverse process, C1, going to the inferior nuchal line. And then you have oblique capitis inferior. These muscles are the pain generator. All the symptoms you're talking about, headaches, hypertonicity in this muscle can pinch the greater occipital nerve, which we talk about in our cervical course, talk about in the dry needling course. Make sure that you're aware of this. From treatment standpoint, these muscles are very, very important, especially if you dry needle your patients. Okay, these muscles are very important. You know how to palpate them. You should know how to assess them. You should know how to needle them. Okay. Okay. Any questions regarding this? Okay. We'll share this presentation or put this on YouTube so that you can go back and relook at it. Okay. But these are the key muscular attachments. If you look from the front, then you have the deep neck flexors. Your longus capitis comes from thoracic spine, attaches on the cervical spine in front. And then you have rectus capitis anterior, okay, attaching in front, okay. Coming from the transverse process of C1, attaching to the foramen magnum, anterior of the foramen magnum, okay. So these are important ones too. This is what we train when we feel that patient has poor deep neck flexor activation. Make sure you're aware of these muscles, okay. Common pattern we see is like inhibition of this and overactivity of these. Okay. So we like to needle them or reduce tension in these muscles, and we like to train them. This is a common pattern we see. Yeah. Yeah. We're going to talk about relationships and different problems that can coexist. Okay. We spoke about vertebral artery that comes out from the foramen transversarium or transverse foramen. We spoke about C1 dorsal ramus suboccipital nerve that sits in this groove. Okay. And C1 ventral ramus that is in front and basically innervates the deep neck flexors. Yeah. We know about the spinal cord and lower medulla just posterior to the odontoid process. So I'm going to show the articulation again. Sits like this. Okay. Yeah. Let's talk about the more important part, the biomechanics. And these models were designed very recently, probably last 2 decades. And this comes from National Upper Cervical Chiropractic Association, where they've done a lot of research on how these movements happen. Okay. So I'll try to explain this. Because my understanding was there's only flexion extension and flexion extension and a little bit of rotation and very little side bending. But I think according to Nuka, there are 6 degrees of freedom. So if this is your C1, so it's like this. It can happen, you can have a flexion, okay? You can have an extension, you can have a lateral flexion, okay? You can have a rotation. We know that there is a lot of rotation at C1 too, okay? A lot of patients who are hypermobile, what else can happen? You can have anterior and posterior glide, okay? Okay. You can have a lateral glide, a lateral translation, which is like this, okay? There's a little bit of give despite the presence of transverse ligament and iliac ligament, and you can have a lateral glide. Or some of the researchers say that in patients with Ehlers-Danlos syndrome or patients who have RA or Down syndrome, you can have some axial compression or distraction, which is a vertical movement. Okay. Okay. When we're going to talk about treatments, I think we're going to talk about neural pathways in more detail, how we can train them at some point. Okay. But so flexion extension, okay, you can have lateral flexion, you can have rotation, then you can have anterior glide, AP glide, you can have a lateral translation or lateral glide, and you can also have axial compression and distraction, which is up and down movement. Okay. Okay. Any questions regarding the biomechanics, guys? I think this is a little bit of a stretch. When I read this stuff, I felt it was a little bit of a stretch, but I think the evidence is overwhelming. But when I look at the problems in the clinic, I can relate to how and why the problems are there. Because the movement at C1 can create wide variety of problems, as I said earlier. Okay. 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 So some of the common positional faults, you can have flexion and extension. Okay. And that can cause head heaviness, suboccipital pain, the muscles we were talking about in the back of the head, they can become hypertonic. Lateral flexion, which I've seen a lot where one transverse process is lower. Okay. So if you feel the transverse process, you feel like the uneven ear height, and one of the transverse process is lower. And that can create cervicogenic headaches. They can cause TMJ tension. Okay. Yeah. Yep. The common ones are where if you feel the transverse process, compression and distraction usually happens in patients who have underlying hypermobility or some collagen tissue disorder. That's what they've seen. More common in those patients, yes. Okay. So talking about axial rotation, where one transverse process is sitting forward. Okay, one transverse process is sitting forward. And that can cause symptoms of vertigo, dizziness, limited neck rotation. I think we're going to talk about anterior and posterior rotation, positional fault in greater detail because it's very, very common. Very, very common. And then you can have anterior and posterior glide, which means that the C1 has decided to just glide anteriorly. Anterior glide is far more common than the posterior glide, which means that the vertebra C1 is sitting a little bit forward. In my understanding and my experience, I've seen that this anterior glide or anteriorly positioned C1, we'll talk about how to measure unevenness of transverse process. I think I'll show you it on patient, and I think I'll show you again. Okay, so when we talk about the positional faults, I think I will show you. Okay, so anterior and posterior glide, which means that this is moving forward or this is moving back, okay, without rotation or without side bending, okay, moving just forward, backward. That can be secondary to a history of whiplash or history of underlying hypermobility, okay. This is associated usually associated with dysautonomia, which we're going to talk about. We're going to talk about something called as POT syndrome. Okay. We'll talk about POT syndrome. And that confuses a lot of people because cervical spine can compress on vagus nerve or can cause irritation of the brain stem and cause brain fog. We'll do the assessment and I think I will show you. Okay, we'll spend time on assessment. When my patient comes in, I just want to talk about wide variety of problems first, and then I think we'll do an assessment. Okay, I've asked a friend to come in and he's going to probably show up at around 7:15, 7:20, and we're going to do an assessment. But I just want to talk about the patient problems first. Okay. So this anterior posterior translation can cause symptoms of dysautonomia. Okay. Where patients can have wide variety of problems. We're going to talk about POT syndrome in greater detail. Okay. And then you can have something called as lateral glide, which can create like facial asymmetry, where patients feel like their one eye is higher, they have visual issues, or they have a lot of neck tension. Okay. The bigger issue is patients who have history of trauma or whiplash. You can have combinations of this, which means that you can have an interior glide, a side bent C1, and a rotated C1. And that is problematic because these patients are hard to assess. You cannot touch, there is no vertebral body, there's no spinous process. All you can feel is transverse process. And that makes it hard to assess, hard to treat, especially if you have problems in more than one plane, right? If it is rotated and side bent and shifted forward, you will find problems, wide variety of problems. Okay. Okay. Yep. We spoke about compression and distraction, where the movement is happening on y-axis, it's vertical movement. Okay. And this can also cause change in the CSF flow, occipital pressure, and brainstem irritation. Yeah. Okay. We're going to talk a little bit about arthrokinematics. I think this is very foundational. If you have attended our lectures before, or if you've gone through the program, you can appreciate how things move. As I explained, the superior facet of the C1 is concave. Okay, condyles are convex. So when you flex, okay, your occipital condyle move in opposite direction. The roll and glide is in opposite direction. So when you do this, they roll forward, glides backwards. Okay, when you extend, exactly opposite happens. Side bending, when you do side bending, okay, what happens is you have a ipsilateral glide, ipsilateral roll, and a contralateral glide, similar to extension and flexion. Okay. Another thing I think we talk about when we talk about C1, C0, C1 nomenclature, if you keep your hand on the occipit and you do a little bit of a side bending, you feel that the occipital condyles are moving medially, inferiorly, and anteriorly. And the nomenclature we use for C01 is that this is something called as MIA. Okay. Which means that when I do a little bit of a side bend, the occipital condyle in the right goes into medial, inferior, anterior, and the opposite condyle moves lateral, posterior, superior. Okay. So I'm going to write this. Same roll, opposite glide. And then remember MIA and LPS. Ipsilateral side goes in Mia. Contralateral side goes in lips. Okay. Okay. Let's talk about arthrokinematics of C1, C2. Okay. So very simple. These joints are flat. When you rotate, see if you rotate to the right glides posteriorly, left glides anteriorly. Okay. Anterior and posterior motion is limited by the transverse ligament. According to NUCA, there is a little bit of movement that can happen, but not a lot. Okay. Okay. We're going to do the screening when my patient comes in because we're going to spend time on this. The examination part, I'll show you how to test it. Okay. We want to spend time talking about positional faults first so that you understand because you just learned the arthrokinematics. So we're going to talk about positional faults first, and I think that makes more sense. Okay. And I was actually treating somebody last night and I saw this anterior rotation positional fault. So just a little bit of visualization is needed. This is my right side. Okay. Anterior rotation fault would be this. Makes sense. You're facing the screen. This is the anterior rotation fault. Okay, which means that one transverse process is anterior to the other. Okay. TP is more prominent on the side of rotation. Okay. And this is very common, super common. Okay. Anterior rotational fault. Okay. When I say anterior rotation fault, you have to understand that C1 is one side of C1 transverse process is rotated anteriorly relative to C0 and C2. Because C1 articulates for two joints, right? You have atlanto-occipital at the top, and then you have atlantoaxial. So C1 transverse process is anterior. You can palpate in supine and prone. You can all palpate on yourself so that you can see how it moves or how it is. Find your mastoid process. Okay, find your mastoid process. Go anterior and inferior, and the lateral mass you'll hit is the transverse process. If you're not sure, you can do a little bit of a no movement and you can feel that moving. Okay. Try to find the C1 transverse process on yourself first. It is a very, very tender area because it has a lot of muscular attachments, right? You're talking about rectus capitis anterior. We spoke about oblique capitis inferior. Okay. They all come from transverse process. So, okay. So this is your C1 transverse process. Make sure you're able to palpate it. If you're not sure, you can try a little bit of side bending. When you do side bending, it starts to disappear. Okay, when you do no movement, you can feel the movement from side to side a little bit. Are you able to palpate or appreciate? C1 transverse process. All of you, this is very important, guys. If you can't palpate C1 transverse process, this lecture is a waste. Okay. Yeah, this lecture is a waste. If you can't palpate C1 transverse process, this lecture is a waste. Because if you're able to palpate on yourself, you'll be able to palpate on the patients. You'll be able to know which side is anterior, which side is posterior, which side is sometimes superior, sometimes inferior. And that happens all the time. So your understanding is very important. Being able to palpate, it's a very easy structure to palpate, but a little bit of visualization is needed. If it's sitting like this, it can go anterior. Okay, this is right. So this is going anterior. Okay, if this is anterior, usually you'll find like the patient would have difficulty turning to the opposite side. So you can remember the mnemonic: right anterior, limited left rotation. Okay, but make sure that you palpate it. That's very important. Okay, I will show you on the patient when the subject comes in, but this is important. Okay, just being able to appreciate is important. So this is the anterior positional fault. okay, where C1 is sitting anteriorly, and you have limited rotation to the opposite side. Okay. Okay. Usual symptoms could be dizziness, headaches, neck tightness, very, very common. Okay. Now we're going to talk about posterior rotational fault. Okay. Which means that this has decided to rotate posteriorly. Okay. Why opposite rotation is affected? Can anybody tell me why opposite rotation is affected? Can anybody tell me why opposite rotation is effective when it's anterior? Anterior roll does not happen. Okay. Anybody else? That could be one explanation, but there's another solid explanation here when it is sitting. What ligament gets stiff? That's a good question. Good answer. What ligament gets stiff? One side of alar ligament. What does alar ligament attaches to? Alar ligament does not attach to C1. It attaches from C2 to the foramen magnum. Okay. The correct answer is transverse ligament. That's what I was looking for. Okay. So basically, transverse ligament is restricting the opposite rotation, and of course, the anterior roll does not happen. Okay. Okay. Let's talk about posterior rotational fault. So this is rotated posteriorly. Okay. Okay. So you'll usually have like restriction to the rotation to the same side. Okay. And you'll have suboccipital headaches. Okay. Unilateral pressure behind the ear or eye. So you'll have pressure here, which we see all the time, right? This is very, very common. Okay. Okay. Then the other positional fault is lateral shear, which is this. Okay. How you will palpate this? Give me 1 second, guys. Okay. So this is lateral shear. Okay. With this, you'll see like ear to shoulder asymmetry. So if you measure the distance from earlobe to shoulder, that distance would be affected. Okay. Okay. So that's very much possible. Another way to actually find this is you will feel like transverse process is much more fuller on one side than the other. Okay. And of course, you can see the shifting in the ear to shoulder asymmetry. Okay. I will show this lateral shear on a patient when we do the exam. Okay. And then you can have a vertical displacement that can happen. Okay. We spoke about this. More common in hypermobility patients, Chiari malformations, EDS, RA, patients with severe concussions, history of severe trauma and whiplash. Okay. Rollover accidents. Another thing that could happen is, which is not super common, is atlantoaxial malpositions. These are also common in patients who have RA or patients who have Down syndrome, where the whole head, which means your occiput and C1 is rotated on C2. Okay. And this is actually different from the first two we discussed, because what is happening here is your C1 is moving forward, moving backward relative to C0 and C2. But in atlantoaxial malposition, what is happening is the whole skull with C1 is rotated on C2. Okay. Okay, so this is a quick cheat sheet to see comparison between anterior rotation fault and posterior rotation fault. Guys, this is very, very common. So this is a good slide to take a picture of if you want to, because you'll see this in the clinic all the time, where transverse process is anterior and prominent, and or posterior deep. Anterior, you have limitation in rotation to the opposite side. In this, you have limitation in the rotation to the same side. Okay. Your anterior rotation brings on hypertonicity in the levator's cap or splenius cervicis, splenius capitis, and posterior rotation fault gives you like suboccipital tightness or suboccipital hypertonicity. Okay. Anterior rotation gives you dizziness, jaw tension, eye pressure, and then posterior rotation gives you this lock feeling that something is locked. Okay. Obviously, treatment is exactly opposite. You have to do the opposite glide. Okay. Okay. We're going to talk a little bit about C1 related syndromes. And I think I'm going to go quickly through this because there are a wide variety of problems. I'll try to discuss some patient problems, but I want to spend time assessing it. I'm okay sharing the slides so that you can look at it. So C1 related syndromes could be classified into these categories. We're going to talk about, and there is some overlap because some symptoms we call it neurological, could be musculoskeletal, but I want to spend time talking about autonomic and vagal stuff more because that is often missed. Okay, that is often missed. So let's talk about neurological and brainstem related syndromes first. Okay, VBI, I think you guys know about it. I mean, this is very, very common. I think I posted a video where I was showing how sometimes a rotational fault could be anterior posterior rotation, can kink the artery. You see the vertebral artery here, can kink the artery, and that can cause symptoms. Okay, related to VBI, you can have vertigo, you can have dizziness, diplopia, dysarthria, drop attack, tinnitus. Usually, we don't want to perform manipulations here. No high velocity stuff. Maybe if this patient needs a referral. Okay, if the symptoms have stabilized, we might consider treating them, but this is definitely a red flag. Okay, so if you look at there's a video on Instagram and I think on Facebook, I think we posted. If you look at the vertebral artery, a rotational fault can sometimes kink the artery. Okay. Okay, you can see, okay, here, and give you wide variety of symptoms. This is fairly common when we talk about neurological and brain-related symptoms. Okay. You guys spoke about dizziness. Dizziness could happen because of involvement of cranial nerve, vestibulocochlear nerve, or some of the extrapyramidal tract that supplies to your cerebellum. Okay, that can cause cervicogenic dizziness, incoordination, balance issues. We know about that, right? And okay, I'm currently seeing a patient who has a lot of face pain, and I think in our cervical module we talk about how sensory efferents to C1, C3 and trigeminal nerve. We typically talk about one nucleus which gets affected. The firing gets affected. There's more firing if you have C1, C3 or C1, C2, C2, C3 dysfunction. Okay. I think, talk about it. I think this is an exam question. If you just finished cohort 3 or cohort 3 final exam, cohort 2 final exam. It's called mesencephalic nucleus. Okay. There's increased firing of this nucleus, giving you symptoms, get face pain. So if you're seeing face pain, you definitely have either a TMJ issue or a C0, C1, C1, C2 issue. Okay. So, and these are some of the hypermobility instability where we were talking about vertical translation of C1. Okay. You can have clumsiness, limb weakness, dysphagia, facial paresthesia, drop attacks. Okay. So these symptoms are common. Okay. Occipital neuralgias are common because we talk about greater occipital nerve, okay, just behind your rectus capitis posterior major, okay, and that if you have a lot of hypertonicity, you can have occipital neuralgia that can give you a lot of pain around this area. Okay. Okay, so these are the common ones. I think we know about all this stuff, but the less common ones are this. Okay. I'm currently seeing a patient in the clinic, very, very interesting presentation. And I was very surprised that she was referred to PT because usually most of the providers are not aware of it. So she has speech issues where at the end of the day, she reports like voice fatigue, where she feels like at the end of the day, she's not able to talk. She's a provider. She talks to patients all the time. And by end of the day, she feels like she's losing her ability to talk. Her voice becomes like hoarse. Okay. And that can be because of the compression of the vagus nerve. If you remember the neuroanatomy of jugular foramen, okay, your 9th, 10th, and 11th, I think that's right. 9th, 10th, and 11th nerve 11th nerve can get compressed secondary to C1 malposition. And that, yeah. And if you know your anatomy, I mean, clinical anatomy, your vocal cords are supplied by a branch of vagus nerve. Okay. Can anybody tell me which one? It's called recurrent laryngeal nerve. I'm writing this so that you remember this. I think I just posted a video on Instagram regarding this. Okay. So your recurrent laryngeal nerve can get entrapped. It's a branch of vagus nerve that can give you symptoms of voice fatigue and hoarseness. Okay. And that can be because of malposition of C1. So if you're seeing somebody who has hoarseness, they have difficulty in talking, and they also have severe neck pain, that could be associated with entrapment of vagus nerve and this nerve. Yeah, recurrent laryngeal. Yeah. Another common symptoms you could have is like SCM weakness. That can happen because of irritation of the 11th nerve close to the jugular foramen. I told you the 9th, 10th, 11th they come out of jugular foramen and they can get compressed. Yeah. So these are brainstem related syndromes, neurological syndromes. And a lot of you are aware of neuralgias, pain, headaches, dizziness. Those are common ones, but these are the less common ones which you should be aware of. Dysphagia can happen because of the 9th nerve. Okay. Okay. Let's talk about the more rare problems that exist with C1 misalignment, which I'm actually seeing one of the other patients. She has POTS. She's diagnosed with POTS. She also has a history of Chiari malformation. Okay, if you know what Chiari malformation is. Okay. She just feels like when she changes positions, she feels like symptoms of hypotension. Okay. Tachycardia on standing, and then lightheadedness, a lot of brain fog, a lot of GI symptoms, which they were relating to gluten intolerance, but POTS can do it. Okay. Because your vagus nerve supplies your enteric system, your gut, so it can do it. So patients who have underlying hypermobility or Ehlers-Danlos, C1 misalignment can cause, C1 misalignment can cause something called as partial orthostatic tachycardia syndrome. Okay. The research on it is still developing, I think evolving, but I think we have enough research where if you're seeing somebody who has a lot of neck hypermobility and some of these symptoms, you might be seeing a patient with POTS. Okay. Has anybody seen a patient with POTS or treated them? Any of the seasoned clinicians who've seen a patient with POTS? No. Okay. So medical doctors will diagnose it as dysautonomia or POTS, but C1 misalignment can also do this. Okay, because this is a byproduct of brainstem irritation and vagal irritation. Okay. Yeah. So I think they seem to coexist, but if I have to talk about vagal irritation syndrome, these are some of the symptoms. You can have palpitations, you can have syncope, you can have chronic cough. Okay. You can have throat tightness. Okay. Yep. POTS will present as kind of symptoms of dysautonomia, where patients will have nausea, brain fog. They will feel lightheaded with positional change. They'll have like a lot of unexplained nausea, unexplained GI symptoms. Okay. And that is because of malalignment of C1, irritating the baroreceptors, irritating the vagus nerve, irritating the brainstem. Okay. 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 So if you're seeing patients with C1 problems and brain fog is confusion, that is what they seem confused, and they struggle to do day-to-day activities. Okay, I've seen patients with brain fog, like they'll just forget they have to go to work or some like basic stuff, basic day-to-day activities they just forget. They'll forget to take shower or something like basic day-to-day activities they'll forget. It's not memory loss, it's just brain fog. They stay confused. Okay. Yeah. Yeah. It's basically confusion is the right word. I mean, brain fog is confusion. Okay. And that confusion is day-to-day basis. And they feel like they have difficulty leading a normal life just because they feel so confused and have this brain fog. Okay. Okay. Is POTS transient? That's a good question. Yeah, it could be transient, where they would do okay for a period of time and then they'll have like flare-ups. That's a good one. That's a good question. It's a really good question. Yeah. Okay. So the idea of doing this is if you're seeing patients with C1 problems and they have some of these symptoms where they have heart problems, they have gut issues, they have nausea, they have brain fog, think about vagal nerve irritation. Think about medullary irritation. Okay. And this is fairly common, I think. Okay. Yep. Okay, let's talk about musculoskeletal and pain syndromes. Okay. Globus sensation is that you feel like you have difficulty swallowing. You feel like heaviness in your throat. That is global sensation. Yeah, I'll write this. Yeah. That is a global sensation. Okay. Yeah. So some of the musculoskeletal and pain syndromes are very common, and they are, we think we discussed about it, spasms, headaches, they're fairly common. TMJ problems coexist. You can have scapular dyskinesia. You can have range of motion deficits. They're very common, right? Thoracic outlet can happen because your muscles that supply the thoracic outlet, your scalenes, they come from the upper cervical, right? So if you have C1 malalignments, it can basically cause problems down the chain. Okay. You can have vertigo and dizziness. I think we spoke about the eighth nerve. We spoke about the vestibular cochlear nerve, right? You can have partial asymmetry. So these are common ones. Okay. Myofascial pain syndrome is common. Neck arm pain syndromes are very common, right? These are the common ones. Okay. Yeah. It's not going to spend too much time on it because I want to spend time on assessment. Okay. Now we're going to talk about vestibular ocular dysfunction, and vestibular ocular dysfunction could be the whole lecture. Actually, this can have wide variety of problems with just vestibular ocular dysfunction associated with C1 malalignment. But we'll talk about the more common ones here. Cervicogenic dizziness. If you have C1 malalignment, the you have kind of a mismatch in the inputs to the brain. So you can feel like your cervical proprioception is affected. You always feel lightheaded and floaty, and you have a blurred vision with turning. Okay. So this is common. Okay. And then you have something called as impaired vestibular ocular reflex, which means that you have difficulty fixing on a gaze. Okay. Okay. And you feel like your vision is bouncy. Some people say they feel like they have floaters in the eye. Okay. And they feel their vision is very unstable especially when they're turning their head. Yeah. So this is common. And this is due to the difficulty in integrating the vestibular nuclei and oculomotor nuclei centers. Okay. And I've seen this is, I think, fairly common. I've seen this a lot. And this can coexist with dizziness. So make sure that you ask about visual stuff if you're seeing somebody who has C1 misalignment. Okay. How's your vision? And people don't associate vision with C1 problems, but I think it do exist. These problems do exist. Okay. Another one is visual midline shift syndrome. I have treated a patient with this problem where patient feels like whenever she's walking, she's leaning on one side or drifting to one side. Okay. And that can happen because of C1 misalignment. It's fairly common. Okay. They feel like when they're walking, they're just walking to one side. Okay. And that can happen. Okay. Some of the clinical pearls, I think the idea is that these problems exist when your vestibular centers and visual centers, they don't integrate well. Okay. And that can happen when you have misalignment of C1. Okay. So make sure that you ask about visual stuff. It's not only about headaches and dizziness. Make sure that you ask about visual stuff. Okay. Okay. Functional movement disorders, I think some of them we have already covered. Scapular dyskinesia is common. Okay, we see problems with scapular tracking, levator scap hypertonicity because of C1 misalignment. Okay, suboccipital hypertonicity we already spent enough time on. You have mandibular dysfunction that can happen where you do mouth opening and mouth tracking is happening where patient is opening the mouth and mouth is deviating to one side. And that can cause problems with fifth nerve, and that can give you symptoms of facial pain. A lot of tension in the masseter, lateral pterygoid, and temporalis. Fairly common. These are the three common muscles that can get impacted because of this tracking. Okay. You might hear like clicking with opening and closing of the mouth. Maybe there is reduced opening, mouth opening. Okay. So definitely correlate C1 problems with TMJ problems. They tend to coexist. Even if you're seeing patients with TMJ, make sure that you check C1. It might be misaligned a little bit. It's very, very common, super common. Okay. Okay. So oculomotor postural shift syndrome, where patients feel like their head is like this, head tilt or forward head lean. And that is also very common with C1. I told you that C1, you can have wide variety of problems where C1 can be rotated and side flexed, okay, in the same person, right? So that can create problems like this. You feel like your head and body orientation is not right. Yeah. Yeah. This is, I think, comes under the category of VOR, where you have difficulty with gaze stabilization, atlantoaxial driven vestibular motor dysfunction. Yeah. Cervicogenic headache, I think we've discussed. Sometimes patients would report symptoms of headaches when they're moving their head. And that's what is functional cervicogenic headache syndrome is. Okay, they don't have pain at rest, no headaches at rest, but whenever they move their neck, they feel like their headaches, that the headaches are worse. Okay. Okay. Let's talk a little bit about connective tissue disorders. I'll share this presentation. This presentation could be probably 200 slides because there is so much information out there on C1 misalignment. But I think I've tried to condense it, and I'll share this on the group or on YouTube. I think whichever you like. And okay. Connective tissue disorders, I don't know how much you see them in India or other parts of the world, but Ehlers-Danlos is super common in the US, creates hypermobility and creates all these rare translations, anterior and posterior, superior and inferior, okay, with Ehlers-Danlos. Yeah. Okay. And then Chiari malformation. I'm currently working with somebody who has Chiari malformation. She has classical symptoms of POTS. She's been diagnosed with dysautonomia. She has history of Chiari malformation, where your cerebral tonsils are displaced inferiorly. Her symptoms are, as one of you said, are transient. She does well for a few weeks and then she has a flare up. And the funny thing is, if you correct the C1, symptoms become better. And because she's hypermobile, it's not hard to correct it. Very simple to correct it. And she does well for like 6 to 8 weeks. And then she says, I think my symptoms are coming back. Can you see me again? Okay. So C1 malalignment and Chiari malformation and POTS. This is a triad. And I'm going to write this because I think there's a lot of literature that is coming out. So if you seen Chiari type 1, plus C1 misalignment plus POTS. This triad is very common. Yeah. And I think I make sure that you're just not restricting your search if you're treating upper neck problems to just headaches and vision or headaches or vestibular system. It should be cardiac, it should be GI, because we know that these things coexist. Okay. Sometimes voice hoarseness, chronic cough. Okay. Okay. These are the references. I think I'm going to go back to the examination part and we'll spend time on doing the examination. We'll start with some basic stuff. And if you've attended our lectures before, you know what I'm talking about. I think I'm going to start with some very foundational stuff, palpate the C1. Okay. It's not hard to palpate, simple to palpate. Try to make a sense of it, how the positional faults can happen. Okay. And then we'll do a little assessment. Okay. Mm. Okay. Okay. So I think we'll start with some alar ligament testing, and then we're going to talk about transverse ligament testing. Okay. So there's a Sharp-Purser test we do. Not a fan of Sharp-Purser test because it is way too aggressive. Yeah. But I'm going to show you alar and transverse ligament testing. if you already know about it, just tune in. Okay. And I'll probably stop sharing so that this is full screen. Okay. Just give me 1 second. I'm trying to arrange this so that it is, so you guys can see. So I'll start with C1 palpation. Okay. And I'll show you how to palpate C1. Okay. So that makes a little bit of sense. Okay. So just lay on your back. Just lay on your back, face up. Okay. So maybe scoot down a little bit. Scoot down a little bit. Thank you. So I'm gonna move the camera close so you guys can see. C1 is super easy to palpate. Okay. You find the mastoid process behind the ear. Okay. And you go anterior, inferior, and the first structure you'll hit is your transverse process. Yeah, this is the transverse process. If you're not sure that you're on the right structure, you can do a little bit of side bending. Ipsilateral side bending should cause C1 to disappear on that side. Okay, ipsilateral side bending should cause, so this is C1. Okay, if I side bend towards, that should cause the C1 to disappear. Okay, it should cause C1 to disappear. Okay, if you're still not sure, you can introduce a little bit of nodding movement, and you should feel a side to side movement of C1 transverse process. Okay. Okay. Is that clear? Are you able to find C1 transverse process on you? Okay. This is very important. If you are not able to find C1 transverse process, this lecture is a waste. This is probably the most important thing. Okay. Now a little bit of visualization is needed. This is how C1 sits here, right? What you're looking for when you're looking for positional fault is which is anterior, which is posterior. Okay. Or you're looking for superior inferior. It would be hard for you to appreciate anterior posterior. Okay. For that, you would require examining the posterior arch, because if posterior arch is too deep, which is sometimes very common, then the C1 has translated anteriorly. Okay. So I'm actually going to show you how to palpate the posterior arch. Okay. And it has a very thick attachment of ligament nuchae. So I think it's very hard to palpate, but I'll show you this. So we'll try to palpate transverse process in prone position one time, and then I think we'll talk about how to palpate posterior arch. Yeah. Do you mind laying on your stomach? Okay. And arms can be on the sides. Okay. So same thing, you find the mastoid process. Okay. And you go anterior, inferior, anterior, medial, and then you hit the first, this is your transverse process. And now what you have to do is from this point, you have to come medially towards, say, the spinous process. It does not have a spinous process, but I think you have to come medially. And you can, I think, appreciate the posterior arch. Okay. So if you find the transverse process, just come medially towards the midline. And I think in some places you can feel the posterior arch. This is the posterior arch. Okay. If you think this is sinking deep, which is possible in patients who have hypermobility, if your range of motion testing is showing you that this patient is moving too much, may have like 95 or 100 degrees of rotation, then this patient falls into the category of hypermobility syndrome. It doesn't hurt to feel the posterior arch, because sometimes you will feel that the posterior arch is just sitting too deep. And if you're not sure, you can keep one hand on the posterior arch and just go a little bit lower so that you can palpate C2. Okay. If you think the posterior arch is much deeper than C2, then you're 100% sure that this is sitting anteriorly. And remember, I think we were talking about how anterior translation and posterior translation can cause symptoms of dysautonomia. So if your patient is presenting with symptoms of dysautonomia, make sure that you palpate the posterior arch. Okay. Yeah. If your patient is presenting with headaches, then you'll tend to find more rotations and side bendings. Okay. So I'm going to do this again one more time so that you remember. This is probably the most important one. And so find the mastoid process, go anterior medial, okay? Find the transverse process. Try to appreciate it by doing a little bit of side bending, gentle side bending, okay? If your patients have dysautonomia, try to go towards the midline, try to feel that arch, okay? Posterior arch. And keep one hand on the posterior arch and find the C2, which I think you'll easily be able to find it because it's probably the biggest spinous process in the neck. And you'll probably, the first thing you'll hit below posterior arch would be C2. If you think that the posterior arch is much deeper than C2 spinous process, then you know that it's anterior translation. These patients will present with some symptoms of dysautonomia, brainstem irritation, vagal irritation, brain fog, cardiac symptoms, tachycardia, orthostatic hypotension. Okay. So physical examination should correlate with your patient's symptoms. Okay. When you're on transverse process, make sure that you appreciate which is anterior, which is posterior. It's very important. You like this and try to see which is anterior, which is posterior, which is inferior, which is superior. Okay. C1 aligns really well, I can tell. But I mean, I think you'll find patients who have inferior, superior, anterior, posterior. Okay. Any questions with this, guys? Always correlate clinical symptoms with examination. That's the best. That's why we do this, right? Any questions? Okay. Now I'm going to show you the ligament testing. We're going to talk about alar ligament and transverse ligament. Okay. Lay on your back. Okay. So transverse ligament, I usually test it in supine. Okay. Do you mind scooting down and you can bend your knees? Scoot down a little bit more for me. Thank you. Yeah. So yeah, you're gonna keep one hand on C2 and another hand on the occiput. So this is what you're doing. You're trying to assess for okay. You're gonna keep one hand on the occiput and then you're gonna lift it up. Okay. All you're doing is just lifting it up. What you should feel here is when you're lifting it up, what you should feel here is that C2 transverse or C2 spinous process, as soon as you lift the head, C2 spinous process should move away from you. So if I have to demonstrate this on a skeleton, which makes, I think, more sense. So I'm keeping one hand on the occiput, right? One hand on C2 spinous process. As I lift this up, the ligament, transverse ligament gets taut. It should push the C2 up. Okay, so the spinous process should start leaving your finger. Okay, I'll do this again. C2 spinous process. Okay, and I lift the head like this. As soon as I lift it, C2 should follow the motion, should move superiorly. Okay. Forward head posture would also have anterior position of posterior arch of C1 mild. I'm not, I mean, and why just C1? It could be C1, C2, C2, C3, right? We know that we are talking about movement of posterior arch in relation to C2. Okay, in forward head posture, you might have the upper cervical just sitting in extension, everything just stuck in extension. Okay, not movement of C1 relative to C2, right? So maybe your C0 to C3 are in relative extension, and they have translated anteriorly. But when we are talking about posterior arch anterior movement, we are talking about movement of C1 relative to C2. Yeah. So if you have forward head, I think I'm just going to explain this. This is very, very simple. So if I have forward head, okay, this is forward head, right? Forward head. So you have movement of the upper cervical spine is in extension, right? This is just a movement of, so all the vertebrae have translated forward. Your C0, C1, C1, C2, they've translated forward. Okay. When we're talking about movement of C1 with relative to C2, you have to, we're talking about just one segment. You're not talking about the whole upper cervical spine being translated forward. Okay, and that's what I was showing you, that C1 posterior arch is just sitting anteriorly with relative to C2. So you keep one hand on spinous process and then you feel the arch. If you think the arch is sitting deeper or anterior, then you're seeing anterior translation, and correlate these symptoms with the stuff I told you, dysautonomia, brainstem. Palpation is of no use if you don't correlate with clinical symptoms, right? Okay, because we see aberrant findings all the time. We see abnormal findings all the time when patients have no symptoms. Do we treat them? Probably not, right? You have misaligned pelvises, we treat. I mean, I think, and sometimes patients are asymptomatic. Okay, so forward head posture is a very simplistic problem compared to what we are discussing. Okay, let's talk about, I think we spoke about transverse ligament testing. I'm going to show you alar ligament testing. You can do it in supine, but for better demonstration, we'll do it in sitting. Okay, you can do it in either position. Do you mind sitting and just facing that way? Yeah. So and this is a very, very simple test, and you shouldn't get this wrong. Yeah. What you're doing here is you're finding C2 spinous process, right? And what you're doing is you're just doing a little bit of a side bend. Okay. When you do side bend, the C2 spinous process deflects to the opposite side. Okay. That's a normal test. Okay. So side bending to the left, the alar ligament gets tight. Alar ligament attaches the odontoid process to the foramen magnum, gets tight. It should deflect. If the deflection is not happening, the test is positive. As soon as I introduce side bending, C2 should just go to the opposite side, spinous process, right? In this case, when I do this, I can just feel like a slight deflection of C2 spinous process in opposite direction. Yeah. Make sense? Okay. Any questions regarding this? Okay. Okay. This was, so we discussed alar ligament, we discussed transverse ligament. I'm going to show you a couple of tests for vertebral artery. Obviously, whenever you're checking vertebral arteries, I think we follow Kerry's guidelines, 2009. That's the best article being published. I think if you go back to the cervical module where we talk about Kerry's guidelines, we test for VBI, we test the vertebral artery, but we run like series of tests. We do a cranial nerve exam. We do check the blood pressure. Okay. But I'm going to show you for the purpose of this class, I'm going to show you how to test vertebral artery in supine and in sitting. Okay. Let's do it in sitting because I think he's already sitting. So what you do is you ask the patient to, do you mind turning to the side? And what you can do is, okay, look at my thumb and just follow my thumb. Okay. Okay. Keep looking, keep turning your head, keep turning your head, keep turning your head. So you introduce like complete rotation. Okay. And you ask the patient to hold that position for like 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. We spoke about how rotation can king the vertebral artery. And if there's a compromise already there, patient can report symptoms of dizziness, patient can report symptoms of double vision, patient can report symptoms of VBI type symptoms. Okay. 5 Ds and 3 Ns. Remember that. Okay. You can check from side to side. You can also do this in supine, which I will demonstrate. Do you mind laying on your back for me? Yeah. So what you do is you create a little bit of extension, and you do it checking in supine, and then you do the same thing. You introduced rotation, okay, extension and rotation, and you maintain that position for 10 seconds and ask the patient's symptoms related to VBI, dizziness, diplopia, they have any difficulty swallowing, okay. 5 Ds and 3 Ns you're gonna ask. You're gonna ask for numbness of face, nystagmus. You're just looking for 5 Ds and 3 Ns. Can anybody name all 5 Ds and 3 Ns in the chat box? Anybody who can name all 5 Ds and 3 Ns in the chat box? Anybody? Okay, I'll try. Diplopia, dysarthria, nausea, numbness of the face, dysphagia, drop attacks is what you missed. And drop attacks can happen with VBI. Sometimes patient starts feeling dizzy when you're turning the neck. Okay, so okay. Numbness of the face. Anything else you guys are missing? You guys are missing 1 or 2. 2 more. You guys are missing 2 more. They start with A, anxiety and ataxia. I think iForm published this piece where they have added 2 more. And I think they published in 2020. So you have 5 Ds and then 2 As and 3 Ns. Yeah. So 2 As are anxiety and ataxia. So make sure you remember that. Yeah. Okay. So you're looking for this. And now I'm going to do a little more testing on, we did alar ligament, we did transverse ligament, we did end range rotation test for vertebrovascular insufficiency. Okay. Another testing you can do is, which I think we do all the time, probably the most safest testing, because we're testing inflection. If you're looking for range of motion deficits, this is what we do. Yeah. You hold the neck in complete flexion. Okay. And you turn from side to side. So when we do this, basically we have locked the whole spine and we are turning. Okay. Ideally, you should get like 45 degrees of rotation on either side. That's a normal, because almost 50% of rotation in the neck comes from C1 to C2, 3. Okay. Okay, you can test this and you can compare side to side. You can look for pain. You can look for restriction. This is not a roll. No, this is not a Helpig-Dykes maneuver. No, this is not Dix-Helpikes. This is not Dix-Helpikes. This is just a mobility testing. When you completely flex the neck, you lock all the segments. And the only segments that could move are C1, C2, C2, C3. And when you do rotation, you're looking for pain and restriction here, not looking for nystagmus or vertigo. You're not looking for that. You're looking for just pain and restriction with this testing. Because you know that when you turn, you should get like at least 45 degrees around that much rotation. So if you're starting in this plane, it should be somewhere in the midline. Okay. And okay. Okay, let's talk about okay, we're going to talk about like C1, C2 glide assessment, and that's important. Okay. It's very similar to what we were doing. Do you mind laying on your stomach again? Yeah. So yeah, so what you're doing here is you're finding the transverse process again. You start with the mastoid process, you go anterior and medial. Okay. And you find the transverse process. You can also try like a little bit of, and you have to be very careful here because that structure could be very, very tender. So you can try like a little bit of a PA on the transverse process and see how patients, whether they feel any symptoms or not. Okay. And you can, yeah. And you can check from side to side if they're reporting any pain reproduction, hard end feel, or hypomobility. Okay. If you feel like side to side difference, if your patient is highly irritable, they're reporting a whole lot of pain, I would not do this. But if they have presenting with low symptoms, I would try a PA on a transverse process while patient is in prone position. Okay. 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 Another thing you can do is ask the patient to sit up. Sit, sit, sit. Okay. And this is another way to test the positional faults. You might face it. Okay. Okay. And this is a functional testing for transverse process. Okay. What you can do is patient is in sitting position. You palpate the transverse process. Okay. And now you're trying to appreciate the movement of the transverse process while patient is slowly turning the neck. So slowly turn your neck to the right. And appreciate the movement of the transverse process. Okay. This is like functional testing. And if you see like abnormal motion, that suggests the positional fault. The idea is that you do perform multiple tests so that you're sure. Another test I would do is if somebody has a lot of symptoms and they have hypermobility, which we were discussing, and if you see like an anterior translation, just doing a suboccipital release sometimes can cause the posterior arch to move posteriorly and can release symptoms. So there's a test where if you have like a lot of hypermobility or anterior translation of posterior arch. I'm going to show you this one. Lay on your back for me, head on this side. Okay. Yeah, so what you do here is you basically do a positional release or suboccipital release. You just hold the skull or hold the occiput in a kind of a distracted position. Okay. And this creates like space for posterior arch to just, if it is translated anteriorly, it will come back down. Okay. And just maintain this. Yeah. For a few seconds and then let it go and observe for change in symptoms. This is done for patients who are hypermobile. And this is a kind of a positional release. You're just holding it. Okay. You're holding a sustained pressure. Okay. You can increase or decrease the pressure according to the patient's need, but you're just holding it. Yeah. This is a very effective technique, and I think a lot of us use it, but okay. Another thing you can do is you can check for balance. You can check for SCM strength, which I'll show you. You can check for VOR. You can do VOR testing. Okay. 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 I'll just show you one more thing, and I think we'll probably call it a day. Okay. And let me demonstrate SCM strength test. Okay. I can show you transverse ligament testing again. That's what you're looking for. I think we do it in supine. And yeah, so patient is in supine lying position. What you're doing is you're finding C2 spinous process, and then all you're doing is just lifting the occiput, lifting the head. Ideally, what should happen is C2 should also follow the lift. It should start moving away from you. It should start moving away from you. Okay. If it doesn't, if it stays right next to your finger, then it means that it's not following the skull, right? You just, all you're doing is just lifting it up, and C2 should just follow it. Yeah. Okay. One more thing I'll demonstrate is like your SCM. We spoke about how your 11th nerve can get affected because of C1 misalignment. So there is a strength test for SCM, sternocleidomastoid. Patient is rotated contralaterally, and you ask the patient to lift up the head and hold. Just lift up and hold here, and patient holds it here, and your force production is posterior lateral. So just hold it there. Don't let me move you. Okay, you can test that. Okay, if you're finding weakness in the head, this is a So you mentioned the anti-rotation of C1. How do you find it? I don't think you can do a test for transverse ligament tightness with C1 rotation. You can only test for if there is an interruption in the ligamentous structure integrity of transverse ligament. I don't think you can test it. Okay. This anatomically makes sense because this is, if I have to show you, The orientation of transverse ligament is, it is posterior to the odontoid process, right? It is posterior to the odontoid process. And when you're stuck in rotation, okay, when you're stuck in rotation, one side is basically pulling it, okay? And that's what's causing basically opposite rotation restriction, okay? Remember that the alar ligament does not attach to the C1. The only structure that connects C1 and C2, the only ligamentous structure that connects C1 and C2 is your transverse ligament. Okay? And it is primarily a restraint in rotation between C1 and C2. Yeah. Any more questions, guys? So I think there will be a follow-up class to this, because when I was making this presentation, I was thinking I would add like some treatments, but this is a lot of information for a 90-minute lecture. And at some point I would do a treatment lecture, talking about treatment ideas, talking about how to improve neural inputs into different vestibular system, visual system, talking about a lot of muscle energy techniques you can use here, because whenever you have symptoms of 5Ds and 3Ns, you don't want to manipulate, right? You're scared to manipulate. And we'll talk about how you can work on a flexed C1, side bend C1, rotated C1, how you can derotate C1, extend C1, flex C1. There are a lot of muscle energy techniques you can use, and a lot of techniques you can use to improve the C1 malalignment, and that can really help a lot of patients. Okay, so we'll probably do a follow-up class to this at some point, maybe next month, maybe in a couple of weeks. I think we'll keep you posted. But at this point, I think we are running a cohort 4. We're starting cohort 4. And if you're interested in being a part of cohort 4, you can reach out to Dr. Dhrumi. She run the admin side of things. And if you have any questions, I think you can always message me on WhatsApp or message Dr. Dhrumi on WhatsApp. And we share stuff like that on our social media. Follow us on Instagram and YouTube. And we talk about complex stuff because patient problems are complex. And I think there is a huge gap between elementary education and advanced stuff. And I think there's a steep learning curve. All of us can learn and be better at what we do. And yeah. Do you have any questions regarding today's lecture? I think we'll post this on YouTube. You can always watch it again. And yeah, stay tuned for more. Yeah. Thank you guys for joining in.